So is there anything I can't do? Haven't found it.
The man you just heard from is Ricky Miller. Ricky is a prime example of how being a patient takes on greater meaning with Floyd Brace Company. A prosthetist spends a great deal of time getting to know each patient, and a special bond is formed. You'll get a good idea of how some of that time is spent as Larry Wiley takes us through the process of making a prosthetic limb.
Well, this is Ricky Miller. He's a patient, but he also is a friend, a hunter, fisherman, and he works here. He's been working here for a number of years, and he's very, very active. You can kind of tell by his residual limb here that these callousing marks here are where he's really been pushing himself without letting us fix his prosthesis the way it should be. So anyhow, today we're going to cast him to make him a new socket, and we're going to take care of these areas that have been kind of plaguing him for a while that he hadn't told us about. Normally when a person comes in for the very first time after their doctor has released them to get a prosthesis, we like to do a thorough evaluation. We'll actually have them bend their leg down, straighten their leg out. We'll try to see how much power they have in their quadriceps as well as their posterior muscle groups. We also check to see if there's any laxity in the knee, to see if we can bend the knee. Bend your knee down a little. Okay, now just relax it, relax it, relax it. Okay, and then we just kind of check for knee instability. If there's no knee instability, then we know how we need to fabricate the prosthesis. Most of the people nowadays get a liner on their leg. Since we're going to be using Ricky's liner, we're going to just roll his liner up, and then I'll show you what happens the very first time you come to Floyd Brace Company to get your prosthesis. We're going to take a casting or take a mold of your leg. Now we can do this digitally with a digitizer, or we can do it by hand. But since we really like the expedience of having everything here in shop, we normally do it by hand. And so your leg would get wrapped up with some plastic like this, okay? Because many times we use somebody else's, or we use a liner that we cast several people over, so we separate your skin from the liner. So we're just going to roll this liner on Ricky's leg. Real simple, kind of like a recipe, okay? Now since this is Ricky's liner, I really didn't have to use the plastic because Ricky's leg is used to wearing this liner. So I pull it up to about that far, and then because I don't want the plaster to get on this liner, I'll wrap it again to kind of protect the liner. These liners are quite expensive. Insurance allows you to get 2 a year. If they break down within that year period of time, they're replaced at no charge. So just bear that in mind, that if your liner breaks down within the first year, we'll replace it at no charge. So now we've wrapped it with saran wrap, so it's in good shape. We're not going to destroy the liner. Next thing we do is we're going to take this little sock and put over his leg, and the only reason we're doing that is because we want to be able to transfer the marks onto the plaster, okay? So we're just going to pull this up, kind of tuck it in at the top to keep it from sliding around, okay? And then I'm going to identify some landmarks on Ricky's residual limb. So we're going to go with the patella, just kind of mark the borders and then just kind of draw what the patella looks like there, okay? Then we're going to look right here at the patellar ligament or the patellar tendon. Sometimes both of those names are used to describe that. The fib head, which is right over here, the fibular head. Okay, we're going to mark the apex of that. Also, Ricky's got a sore spot here that he showed me. We're going to mark that. Kind of coincides with his tibial tuberosity. And then we're going to come down here and mark the distal end of his tibia. So come around, circle it up, lateral tibial flare, kind of like that. And then give us a little line right there to kind of mark the cut into the bone. Ricky's not a real big guy, so his socket's going to be pretty small. We'll do the medial condyle there, just kind of mark that, and then we'll mark the apex, excuse me, of the medial condyle, and then just kind of mark some of the fleshy areas. So since Ricky's leg is so short, one of the problems that we have is finding an area on his leg where we can apply pressure while offloading those areas that are pressure sensitive. So why don't you talk for a minute, Ricky, and just kind of describe some of those painful spots that you've had in the past and how we've worked to rectify those.
It's usually been these two spots right here and in the beginning when I was first got my leg, we wanted to cut holes in it just to relieve the areas. Now
and that works really well because we have an inner liner that he wears, so we can cut a hole, and then he would have the hole there, and then we push the inner liner out, you know, so that it's so that it relieves that spot.
Sometimes they'll put pads in them. There's many different ways.
And one of the things to bear in mind is that Ricky, we snuck a little covert device into Ricky's leg one day to determine how far he walks in the course of a day. It recorded his activity for the entire week, and when we downloaded it on the computer, we discovered that Ricky takes about 15,000 steps a day. Some of those are inside, some of those are outside, but that was equivalent to approximately 3 miles that he walks in a day. That probably far surpasses the normal, everyday, able-bodied person that's not missing a limb. So, you know, for Ricky to have spots on his leg that may be a little sore would be just like me kicking my shoes off at the end of the day and saying, boy, my feet are sore. So, you know, we really strive to keep him comfortable in his leg, and he definitely does over and above what most people do, even able-bodied people. So we're very proud of that fact. We want to keep him going. So now I've wrapped him once with elastic. Now I'm wrapping him with a rigid. Okay. A lot of people nowadays are actually going kind of an easy route of using a digitizer, and then what they do after they digitize the leg, they send the digitized image to a fabricator, which is off-site. They have to do that because the carvers that actually carve the molds are so expensive. But instead of investing in a carver, we actually invested in skilled technicians to help us fabricate our prostheses. We have about 30 people that work with Floyd Brace Company, and many of them are technicians. Even the people that are clinicians can fabricate their own items. Now this will set up pretty soon. Just going to kind of work it around a little bit. Have you been in any pain during this casting procedure?
No, none. It's actually kind of cold.
I think what happens when people see that we're casting them, it kind of goes back to when maybe their leg was hurting and the doctor had to cast it. But this is just very non-invasive. There's no adverse pressures. Once we get the cast, we'll take it in the back. And I've asked them to kind of clean it up a little bit in the back so we can take some pictures back there and let the people see what happens next. So right now we're just kind of identifying outside of the mold those areas that we want to be able to offload, and then we'll see how those coincide with the inside of where we put the blue indelible markers. That pencil that I used earlier, it has an ink in it that will actually transfer from the sock to the casting. So I'll just pull my gloves off so I won't make such a mess, and then we'll start unwrapping all this stuff. Okay, there we go. So you can see that the marks that I put on the sock actually transferred very readily inside the socket. So what that allows me to do now is I take this back into the back room and we'll drape this and fill it, make a molding of this cast, and then we'll modify that to make his prosthesis.